look at it, what would I do if it were my eyes? Drops, number one, there's compliance issues, but there's also toxicity to the eye issues. But in a silent disease like glaucoma, where we don't know you're losing vision, I think you want to intervene earlier. And I think nowadays with MIGS, lasers, there's so many sort of procedures that can treat the disease to avoid drops and not have to be dependent on that. There are a few different ways. I look at, let's say, glaucoma like a sink, and there's two ways to decrease that fluid level in the sink. You can either turn the faucet down to decrease the fluid going into the sink, or you can open up the drain to allow the fluid to go out of the sink. And so there are surgical interventions that can increase that outflow, more or less increase the drain. A lot of the stents or canaloplasties, those techniques can help with outflow, but there's also procedures that can allow for decreased production of aqueous. For example, there's lasers that can treat the ciliary body, ECP, can decrease that pressure through that way. So I think it's reasonable to consider both approaches depending on that patient's disease and how you want to approach it. Yeah, ab externo and ab interno laser, both valid technologies. Depends, if you're already going to be inside the eye, for example, during cataract surgery, it's easier to add an ab external laser technique ab external. It just adds a simple little step to apply laser when you have an incision into the eye. Now, however, if the patient is not having cataract surgery, it's a virgin eye or a phakic eye, and you're doing an intervention, maybe it's better to do more ab external and apply laser from outside of the eye without going intraocular. So a lot of times it depends, are there other comorbidities? In particular, the most common comorbidity would be cataracts. And so if you're treating cataract, it's easier to go ab internal in that case rather than ab external. What's great about ECP is a very innovative technique to have intraoperative laser coupled with visualization. So you have this endoscopic camera that gives you the view of inside the eye. It's one of the only times in ocular surgery that we have a camera that goes inside the eye. So they have this scope inside the eye that allows you to visualize where the ciliary body is, and you can deliver that energy to the ciliary body in a very controlled fashion to decrease that aqueous production. It's very challenging to have a procedure or any other techniques to decrease aqueous production. ECP is really the main device that we do at the time of cataract surgery to decrease that aqueous production. When I first incorporated ECP, I did see some inflammation, and thus I sort of limited the use. But now with modern day techniques, in particular, two techniques that have helped with the adoption of ECP. One is intracameral steroids at the time of cataract surgery. By adding steroids inside the eye, decreases that incidence or helps eliminate that incidence of inflammation. And a second intervention that we do on all our patients is an NSAID. So having an NSAID drop really decreases that inflammation. So now my ECP cases have the same inflammation rate as a standard cataract surgery alone, simply by adding intracameral steroids and postoperative NSAIDs. So for me, ECP is a great intervention.